Hello, good evening, good afternoon, good day, wherever you are in the world, and welcome to the Black Belt Academy of Surgical Skills. My name is David O'Regan. I am a retired cardiac surgeon and a professor in the Medical Education Research and Development Unit in the Faculty of Medicine at the University of Malaya. Our production engineer, Dr. Prajita in New Delhi, is on holiday, and I'll be admitting people, so if there's a pause admitting, apologies. We are delighted that we are reaching 23 countries across the globe, slowly increasing and will increase further only by way of word of mouth. If you are enjoying these sessions, please do recommend your colleagues following. This Saturday coming, on the 7th, we're going to have our second grading system at the Clinical Skills Unit in the Faculty of Medicine at the University of Malaya. 6 candidates are going to be going for the yellow belt, and I hope 3 new candidates will be joining for their red belts. This is a good start for our first face-to-face sessions. We have fun on Fridays practicing on the tables, bedside tables, that we borrow from the Clinical Skills Unit. You will note that they adjust to the appropriate heights because the very basis of what we teach is dependent on a good foundation, and that begins with posture. We have submitted a paper on our scoring system for the 12 perfectly radial sutures, and just in the process of resubmitting the paper looking at objective structured assessment skills. My fellow senseis, Adesh and Vinesh, and the student red belts coming on Saturday are participating in the study, as well as Sensei Chris and John, Sri and myself. We are looking at what I'm demonstrating this evening is a deconstruction of skin suturing. Now, skin suturing has evolved from raw survival to refined scientific practice over thousands of years. Prehistoric humans quickly learned that open wounds led to blood loss and fatal infection. So they experimented with closing skin with whatever nature provided: plant fibers, animal sinew, dried tendons, strips of hide, human or horse hair, thorns with sharpened bones used as primitive needles. Before metal clips or sutures, some healers actually used soldier ants as living wound clumps. They'd pull the wound edges together, let the ant bite across it, the mandibles locked shut, and the body was twisted off, and the head stayed attached like a natural stapler. It sounds wild, but it actually worked. A strong grip, biodegradable, and sterile by nature, and this must have been one of the earliest examples of biological surgical technology. As civilizations developed, this practical knowledge became formal medicine, and in ancient Egypt, the medical papyri describe cleaning and closing wounds with linen, emphasizing blood control and protection. In India, at about 600 BC, Sushruta gave a remarkably advanced descriptions of suturing, including different stitch patterns, when wounds should be closed or left open, and whether to use materials such as silk or cotton, horsehair, or sinew. He stressed precise wound alignment and gentle tissue handling, the principle that remains the core of surgical teaching today. Greek and Roman physicians like Hippocrates and Galen expanded anatomical understanding and described deeper tissues, though without knowledge of microbes, infection, remained the main cause of death after injury or surgery. In medieval Europe, surgeons were often barbers. On the battlefields, they stitched sword and arrow wounds with coarse silk or linen, often without anesthesia. In these cases, speed mattered more than elegance, and many died from infection, but skilled hands could mean the difference between life and death. And suturing became associated with a decisive manual skill under pressure, a legacy that perhaps still defies trauma surgery. Some used catgut and noticed this dissolved in the body. As you know, catgut is not from cats, but from sheep or goat intestine, and became famous because the body could absorb it. The story goes that instrument makers noticed that dried intestinal strings used in violins softened and broke down when wet, and surgeons realized this could be used internally, so stitches wouldn't need removal. And this insight laid the foundation for absorbable sutures and a massive surgical revelation. But of course, our famous friend, John Lister, comes in. Before him, wounds rotted after being stitched, and surgeons thought pus was laudable because it was the body expelling evil vapors. Lister introduced antiseptic spray and sterile techniques in the 1860s, and suddenly sutures helped healing instead of trapping infection. Skin closure shifted from close and hope to a truly controlled biological repair. And this is when stitching really became mainstream in modern surgery. Surgeons started sterilizing instruments, suture materials, and catgut was processed more reliably, introducing the key distinction between absorbable and non-absorbable sutures. Of course, the 20th century led and chemistry and engineering has totally reshaped this field. Synthetic materials such as nylon, polypropylene or proline or polyglactin, vicryl offered predictable strength, flexibility, and a reduced tissue reaction. The first cosmetic closures started early because early surgery focused not on survival and not on appearance. But facial injuries pushed innovation. In ancient India, nasal reconstruction was commonplace after a punishment for amputation of the nose, and this required delicate skin suturing and drove the development of fine materials and careful edge alignment. The roots of plastic surgery and cosmetic surgery and closure are the same. Atraumatic needles, where the suture swathed directly onto needle, reduce tissue damage. The knowledge of skin lines, Langer's lines, improved cosmetic outcomes. Modern skin closure considers biomechanics, blood supply, scar formation, aesthetics, with options including subcuticular sutures, staples, tissue adhesives, barb sutures, vacuum-assisted closures, and even robotic assistance. In the 20th century, surgeons realized scars partly from stitch marks crossing the skin, and they hurried and developed a running subcuticular stitch, which was hidden under the skin surface. Same closure strength, less scarring, reflecting a shift in thinking, not just healing, but healing beautifully. And it's always struck me that we appear to leave the most junior surgeon in theatre to close. Yes, skin closure is a requirement, level 3 requirement for the Malaysian Medical Council. It's also required by the GMC. But have you considered this? that the wound you leave on the patient is your indelible signature. When you have done the operation, you've probably done hundreds of them. You will not remember the patient, but they will look at their scar and remember everything you said, everything you did, and how you made them feel. In that regard, your wound closure is your indelible signature, and therefore it's beholden on us to get it right. Today, robotic systems replace sutures inside the body with millimeter precision. The technology is futuristic, it is around the corner, but the concept is identical to prehistoric humans pulling skin edges together with sinew. Different tissues, the same biological truth. And yet across the millennia innovation, the fundamental concept has not changed. Accurately oppose the wound edges with minimal trauma and tension so the body can restore its integrity. But the story is all about hands and precision and respect for tissue. And this is where our story begins in the deconstruction. I'd like you to put your hands together, separate your fingers, thumb to thumb, index, ring, middle ring, and baby finger. Now, in this position, everything is aligned and perfectly opposite. These are the basics of all stitching, not only of skin, but anastomosis, etc. Because if they're not aligned, what happens? You get a dislocation. Furthermore, if you look at your fingers, tip to tip, and look at your index fingers, the creases at the distal interphalangeal joint, the intermediate and the metacarpal phalangeal joints, the creases are aligned. In the same similar manner, your entry and exit either side of a wound should be aligned. If not, we get a slip. And the common problem that we face in surgery is if we do not get them equal and opposite, we get a dislocation, or if we do not enter and exit at the same distance from the edges, we get a slip. And this is where the complications arise, dislocation and slip. Now, you don't see that practicing on a silastic model. The Hounsfield units for a silastic model are 240, which is way off the spectrum of normal human tissue. Yet, the banana in a CT scan has the Hounsfield units of 40 to 80. This is akin to your normal tissue, vascular tissue, bowel, and soft tissue. The advantage here, as you know, if you damage the skin of the banana, the phenyl oxidases in the skin turn black with air, and that gives you an immediate feedback on what you're doing. So I recommend, and what's become synonymous with the Black Belt Academy, is the Cavendish banana. I'll make you laugh. I did write to the marketing director of Door Bananas to explain what we're doing, asking if he wanted to sponsor. I did this because actually my uncle was a vice president of Door, since deceased. So I even look at the shape of the banana, and what I want to have is really two flat surfaces, because that gives you two surfaces to work on. So we'll use this banana, and we'll talk you through what I mean. So we'll come over to the table and take your focus. Now, in deconstructing it, we're going to, and this is a practice for incision, you can come to later. Remember, hold the blade like a knife, hold the sagittal plane, finger down the blade, and you should be able to take the blade through the skin of the banana without cutting the flesh underneath. But let's say that is the incision. I'll focus more because I'll have to open that up a bit because it's not appealing. There you go. I've opened it up a little bit. So the simple task is, I want you to take a needle, doesn't matter what size needle, and in this exercise, I do not mind whether you're sitting or standing. The principle is the same. Really, for a needle, I'll just come back up a second to explain. All needles are actually made on a curve. And for a needle to be used properly on a curve, the alignment is very simple. Needles are made on a curve for us to operate at depth, but also to be able to move them accurately. And to move them accurately, we need to enter the needle on the curve and deliver it on the curve and exit. For this to happen, we have to recognize that there is simple geometry involved. Euclid described the relationship between perpendiculars and circles. And indeed, with a compass, you can bisect a line or draw a perpendicular on the end of the line using a combination of circles. And 90 degrees is fourth part of the circle, which is fabulous news because we are hardwired to see 90 degrees. Now, I've previously demonstrated a 88.5 degrees and 90 degrees on this program, and you've clearly seen the difference. That is because if you look around you, you are surrounded by 90 degrees. The windows, the doors, the tiles on the floors, the tables is all 90. This is good news for understanding this alignment and avoiding dislocation and slip. What we want is the needle 90 degrees to the tissue. We want the needle then 90 degrees across the tissue, and then the needle to enter 90 degrees into the tissue. Now, this sounds straightforward, but it is difficult. And a suture pad would not give you that feedback, but our banana will, as we'll demonstrate. The 90 degrees is important, and those of you who stitched a button on a shirt will realize if you don't go in to the fabric at 90 degrees, it is difficult because of the warp and weft of the tissue. If you come in at an angle, your needle won't go through. Let's take you over to demonstrate that and also point out that many of you might have marveled at the skill of the Chinese divers who scored 10 at the Olympics because they entered the pool without a splash. And they entered the pool without a splash because they were 90 degrees. So first off, on your banana, try holding the needle. That's too far back. But if I try and rotate it in, you can see that needle is not entering the tissue at 90 degrees. It is entering at an awkward angle. I will do this, and as I do this, I can feel and actually see the needles gouging banana. Whereas if I position the needle properly and rotate it back so it's pointing in, on this side, I am pinpricking the banana. And we'll see in a few minutes the difference. So what we need to do is ensure our needle's in the sagittal plane 90 degrees to the banana. We rotate it back, point it 90 degrees into the banana, and simply rotate it out. And what we have to look for, and what is difficult, is the distance between the entry and the exit should be exactly the same. The thread follows the needle. Having placed the needle 90 degrees to the tissue, that placing enables me to space. I can see where I went in previously, and I can see the space I need, and I'm looking for about 1 centimeter. I'm going to rotate it back. I'm going to place my needle through, and this exercise we're taking the needle all the way through the banana, all the way through. And I just want you to do 5. Place 90 degrees to the tissue, and I can see my spacing since the last one. Rotate it back and rotate it forward. One centimeter from the last one. Now I'm going to put in a couple of deliberately bad stitches. Well, these might be bad until we start analyzing it. But to demonstrate the power of this model, I'm going to, once I've done the 5, do a couple of bad stitches deliberately. So you can see the difference. Okay, so as we wait and let this develop, and we'll just dim the lighting a little bit perhaps, and focus in a bit more, you will now see the entry and exit points on this banana. You cannot see that on a suture pad. And what we need to do, if that's the line of the incision, I need to take my rule above that line and see how many of my entry points on that line. And if I look at that, and that, 1, 2, 3, 4, 5 are on the line. That's usually very easy on entry. But if I take this along the bottom, I've now got 1, 2, 3, 4, and I've missed it here, wrong. Okay? Then what I want to say is if I look at this, and let's come down further. If I look at this, if I measure there to the wound edge is 6 millimeters, there to that edge is 6.5. So it's not quite equidistant. That's 6 millimeters, and that is, 6.5 millimeters. There's a slight difference. But if I scored it all the way along, depends, not depends, that's 6, 6, 6, 6. So they are equidistant from the edge. I then want to see how many of them are perpendicularly opposite. 1, 2, 3, and if I look at this one, that's not perpendicularly opposite. That's slightly off there. That's 4. And if I look at this one, that's opposite, but it wasn't on the line. If you look at the other 2 entries, that there is a clean mark of the needle coming out of the banana. Okay, that's a clean mark. That is a skid, whereas an actual tear, and that's a tear. But that there is a slight skid. And what I want to see is that is a clean exit, clean entry. That's a slight skid, that's a skid, that's a tear, that's a tear. Remember, I said to you I wanted to do some awkward stitches to demonstrate the difference. Now, I don't think a suture pad can give you that much information. And what me and my fellow senseis and student colleagues are doing are scoring a series of bananas like this and looking at inter-class correlation. But you can do this yourself, and you can score yourself, and we will actually make this available online when the results come in. Question: did I enter correctly? And all five were correct. Are the distances equal between the vertical lines? Let's do that. That's a centimeter, just under a centimeter, just under a centimeter, just under a centimeter. If anything, if you look at it, we'll come down, we'll look at it in detail, and my colleagues who are in the scoring process will look at this. That is 9.5 millimeters. That's 9.5 millimeters. Ooh, that's 9 millimeters. And that's 9.5 millimeters. So they're all pretty equidistant. The entry point was all on the line, and the exit point, 4 on the line, but 1 was low, that was that one. And as far as opposite is concerned, 4 were opposite, but that one was off the line there. So I get 2 marks down, that one and that one there. And this translates into a score. Now, to enable you to practice, and I've done this without any lines, but the way you can practice this and help your deconstruction is make an incision in a banana, mark off 5 marks, 1, 2, 3, 4, 5, 5, 1, 2, 3, 4, 5. Make sure that you draw a perpendicular line across the incision at each point. And this is akin to many people playing sport, golf, and others using lines and props to get your eye in. Because stitching and perfectionist stitching is actually training your eye on distances, placements. So with those, that side I did it without any marks. This side, I've got the marks, and you can do the same. Place your needle. Make sure that it's 90 degrees to the tissue. Okay? Make sure that plane is 90 degrees to the tissue. Make sure when you rotate the needle back that you can rotate the needle back so it's 90 degrees into the tissue. Now, how did the gouging do? Let me just show you that. That there is the needle entering at a funny angle. Let's just focus on that. That's not entering the banana at 90 degrees. You can see the gouging of the needle going in. By contrast, on the other side, look at that. I'm even going to zoom down even further, because not only can you see it, you can feel it. And I urge you to try it yourself. Simply 90 degrees to the tissue. There you go. And I'm literally pinpricking. And it's the lightest of touches to take it through. You can see that needle at 90 degrees. By contrast, as I said, this side, we weren't at 90 degrees, and now I'm gouging. So that 90 degrees into the tissue is of critical importance, as you know, when stitching a button. There's no different to stitching the tissue. So here are the geometrical alignments. 90 degrees to the tissue. There you go. All right. Rotate it back so you're 90 degrees into the tissue. And then you rotate it. And what you should see is, all being well, it comes out on the line. So I'm going to focus in on this again. You can see that's not on the line. Okay. So we try again. Place it, point it, rotate it. Is it on the line? It's come out the other side now. Place it, point it, rotate it. Again, slightly off. It's touching, but it's slightly off. Place it. Point it. And rotate it. Touching the line. There and there. Equal spaces. Take it out. Touching the line. And there, slightly further down. So this exercise is here to discipline you on your spacing, pointing, and rotating, and ensuring that your accurate rotation comes out on the line. So that is on the line, but the distance there and the distance there are almost. Maybe I'll put a rule to that. That's 6 millimeters too, and that's 7 millimeters beyond, 8 millimeters beyond. So those distances are not the same. Ideally, when practicing, one needs to get that distance and that distance exactly correct. This is critical, basic skill to all stitching. And in this skill, we are simply going in and out of the banana. Okay. That now is on the line and the spacing is correct. And we need to repeat that. A bit longer there. So that's not good. To do it right is actually fiendishly difficult. But to do it right, and we've got to practice until we can't get it wrong. Slightly longer that side, but on the line. But you see the point of this exercise. This is enabling you to practice your entry, your exit, your rotation, and on the line. And in the end, as I did in the beginning, you can actually score yourself and practice. Now, we have not used the forcep, and we deliberately have not used the forcep because you'll notice that as the needle rotated through the tissue, if you're perfectly on the curve and you've gone in at 90 degrees and you've rotated the needle and it's coming out at 90 degrees, the tissue holds the needle in position. Now, you can only do that when the two edges, as in this case, are sitting close together. The problem is that this 90 degrees doesn't apply when you've got a wound that is actually separated like that. And if it's separated like that, 90 degrees that side is there, 90 degrees that side is there, and put those two vectors together, you see my index fingers are are describing an angle of about 85, 90 degrees. You cannot, therefore, go through this side and torque it through to go through that side without it tearing. We will try that on the banana, and you can see for yourself. Let us actually take another banana and make another incision. Note that I go for the flat on both sides, so it makes it easier. Come over. And I'm going to separate the two edges like that, okay? Also, in this, I'm assessing how far I cut into the banana. And I scratched the surface, but I didn't cut the flesh with a knife. So it becomes a knife practice skill as well. So here, if I come through this side, and I try and come through this side as well, you see what's happening? I am tearing the banana, okay? So I cannot come through one side, particularly if they're separated. Let's separate it a bit further. I might actually exaggerate this by taking a bit of more skin out. So we've got an fusiform excision. Okay, so I might demonstrate it with this. So if I try coming through the banana this side, and in the same go, try and take it out this side, what am I doing? Look at the injury I've created going into the banana there. Okay, we'll try that again. I come through this side, and I try going through that side. I cannot. Okay, it tears, and I'm creating injury in the banana. What I have to remember is if I take a linear incision, now we're going to introduce the forceps. If I lift the skin edge, up, I'm effectively separating the two edges of the wound. The entry point there is 90 degrees, entry point there is 90 degrees. As you can see, it subtends the angle of 85 degrees. I cannot, therefore, force my needle through both sides. So if we're now going to practice using forceps, and we've discussed forceps before, the problem is that with many people, in using the forceps, they grab the tissue. And if you start grabbing the tissue like that, you can see that is leaving nasty bite marks on these Adson forceps. So we do not want you to use your forceps to grab the tissue. What we need to do is lift the edge up without damaging it, take the needle in to the wound, and now the trick is, and you're learning, lift the other side up as well, come out, imagining you are on that line, equal and almost opposite, from there to there and on the line, without touching a banana. The plastic surgeons would recommend using a skin hook that avoids the pinch injury of the forceps. If you pinch yourself like that, you will find that you've got a force in male of 35 newtons and women of 25 newtons. Pressure is force over area. And if you look at the end of any forceps and take that, let's say, as 5 millimeters squared, and I said you're generating a force of 35 newtons, 35 newtons over 5 millimeters squared. Well, it's interesting that many medical students don't work this out. Turns out to be 7 million Newton meters squared. That's 820 times your car tire pressure, or 8,000 kilopascals. So the final deconstruction of this is, can you lift the skin edges? Take your needle into the banana cleanly without touching the banana flesh underneath. Lift the other skin edge and come out equal and opposite, same distance and opposite from the wound edge. Then, and only then, will you get the two edges coming together in a master, cleanly and slightly everted. As I said, the plastic surgeons use a hook, so they avoid any possible problems with crushing tissue, and use a nerve hook either side to gently elevate the tissue and take the needle through. Equal and opposite. Equal and opposite. Okay, that's not quite opposite, and it's around the edge, so we'll try again. But to get to this stage of practice, you really need to be practicing using lines. Remember, I'm talking about interrupted sutures here, and practicing rotation, entry, exit, and pickup of the needle. Thing is that this applies to every single stitch that you do, no matter how big or small the needle. And if this was a continuous suture, from there to there to there to there, the same place, point, and rotate must be applied throughout. The problem is that people are so keen on stitch, 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 they forget to set up and stitch, set up and stitch. And it's this setup and the 90 degrees that is part of learning the precision and accuracy of stitching. Now, in the beginning, it might feel laborious and you're not going to practice this. But I can promise you in the end, you'll end up with more accurate stitching, a better feel of the tissue, and cleaner wounds with less trauma. Now, as I take this needle through, and we've discussed previously, you'll see that the needle is coming out at 90 degrees on the curve there. If I take it to the point where I can pick it up again, I apply the needle, I deliver it on the curve, and I pick up the needle. My needle is in the right position to use again. So we've deconstructed the basics of skin suturing. And that is simply down to, as I described, ensuring that you're equal and opposite all the time. Equal and opposite. And be deliberate in your practice on your banana. It'll give you immediate and visible feedback. The next stage of this is actually to understand, really, we need to be able to tie knots. And tying of a knot is likewise important because, as we described last week, if it's too tight, it strangulates the tissue. If it's too loose, it's not going to bring the edges together. And remember that the thread follows the needle. And if your needle control isn't very good, your thread is not going to be equal and opposite. And when you tie the knot, the dislocation and slip on your skin suturing is going to be even worse. So we will come back to instrument tying, but as part of the deconstruction, we will cover some of the basics today. And we're not tying on a banana. I am taking it through on the scissors, an instrument tying, a bit of thread to that. So there's my needle holder. I'm going to go 1, 2, you see, anti-clockwise around the needle holder. I pick up the short end and I take this away. And as I take it away, you'll see that ends up as a flat knot at the bottom. I've covered knots before. I can lock it up to hold it in the position gently and then come clockwise around, pick the short end up again and bring it towards me. And that ends up as a square knot. Anti-clockwise and away, clockwise and towards. You only need to put 3 throws on top that initial knot. Remember then, when cutting the knot, to actually cut it so it's not too short, so it comes undone, and not too long, so it gets in the way. And we're going to be criticized for using Macintosh scissors here to do this, but it's a fine suture. And there you have it. Now, for those of you who want to extend this model further and will want to, there you go, secure, tied without lifting this up, and I can't move it along the barrel, the ring of the scissors, a secure tie. So one way of actually dealing with a closing that accurately and pretending it's a suture pad, because if you try and suture the skin together with the banana flesh present, it's going to tear out. So the idea here is take a teaspoon and literally take out the center of your banana. You can, of course, eat your banana. You can't eat the suture pad. And now you've got the perfect suture pad for testing or stitching. You can see the 2 edges are there. And let's see if I've got a suture here. We'll try. Indeed, you can still leave all the lines on the banana to help you with the stitching and to remind you of the placing. Lifting the edges delicately from inside out, coming out on the line. There you go. Keep it a short end. Anti-clockwise twice. Take it away. I'm going to lock it up there. Clockwise. Towards me. And anti-clockwise away. There. And I've got to do that without tearing the banana. And you can look at your suture. And we'll zoom in. We'll look at the suture from the inside. There you go. Okay, that's the suture on the inside. And really your suture needs to be opposing the tissues and slightly everting the tissues as well. So with a simple Cavendish ripened scale between 4 and 5, we have now deconstructed skin suturing and given you an opportunity to actually see and feel the tissues as you do it. And I'd recommend you do it in all those stages, from a simple line across the banana, simple rotation, and then using your forceps. Remembering, if you come back to the forceps, look at the full thickness damage to that banana skin on that because of the 8 million Newton meters squared pressure across the banana. I can take this further as far as scoring is concerned. Look at somebody stitching a banana and count the scratch marks as they do it. This now becomes a comprehensive, objective way of assessing somebody stitching skin. But to be honest, it can apply to anything. So with that, I am going to invite my fellow senseis to contribute their thoughts and observations to the exercise. And I hope the two students, Adesh, fellow sensei Adesh, who's been doing this, and Vinish, who's also been practicing, could offer their insights into their practice with a banana and this model. So, Prof. Sile, Sensei Kelly, Adesh and Vinish, are you there?
I'm not sure that Vinesh and Ardesh are there. They're
Okay.
not in our room.
Okay.
Can you see them?
No, unfortunately, they're not.
No.
They're not.
Okay.
Never mind. Never mind. But Prof. Sile and Prof. Kelly, your thoughts on the model and
Well,
deconstruct.
thoroughly enjoyed that, as always. I mean, you've demonstrated how difficult it is. And it was interesting watching you coming out one side of the line, going back and coming out the other side of the line.
Mm-hmm.
And you were even attempting to torque it in between, and it wasn't doing what you wanted it to do.
Mm-hmm.
So it's not an easy model, and you demonstrated that. Part of the challenge is, although you're saying it's on a flat surface, your camera is not vertically over the banana, and so one surface is falling away from you.
Mm-hmm.
So the audience doesn't see it coming out.
Right.
So you're marking it in 3 dimensions, but we're viewing it in 2 dimensions.
Sure. So there was the marking when I first demonstrated it. And to get it perfect is extremely difficult. So I had one below the line and one off the line, but it was equidistant with even spacing.
Yeah,
But you can see how difficult it is to get it right all the time. But
absolutely.
taking the flesh out, it has given me a wonderful suture pad now.
Yeah,
And I have got colleagues, students around the globe who have tried stitching this. And if you're watching, do send me pictures of your interrupted sutures in a banana. We have some in the library from the Blackwell Academy where people have done exactly that. And to do it well, is impressive, very impressive. The point being with this is that it's not just stitch, stitch, stitch. I hope to have emphasized and demonstrated that you have to take care in your setup of your stitch. But the other thing is also appreciating the anatomy of the needle, and which we'll discuss in next week's session. Prof. Sile, your observations.
Good evening, Prof. Can you hear me?
Of course.
Sorry. Hello, how are you, Prof. Chris? Yeah.
So your observations on the banana model, Prof. Sile.
That is much interesting, and as you mentioned that the skill, as much as you practice, and it's become more precise, and so it's like kind of you mentioned about patient satisfaction. how beautiful the suture is. And then not only the patient satisfied, and we ourselves, you yourself satisfy, that we always mention about job satisfaction, whatever you do with your own passion, and then you got it the best results, that's make you more motivated to do that. So that the message you give to the student. During the silent mentor program, previously before you join, we have a concept of all the wound must close, all right, before, in the middle of the night, before they rest for that particular day, and before we put them down into the deep freeze again for the night rest for the silent mentors. So it's like we just, suture is make sure we close, but when you, yes, but when you join it, then you mention about that, because they are so dedicated, and for their unconditional love, we should respect them. So it's like no one sees, no family member sees, even our silent mentors, they themselves did not know about that, how the suture beautiful. But as a core value, it with respect, and they deserve to have the beautiful, nice, neat, and perfect sutures, in fact, before
Indeed.
we coffin them. So yes, Prof. So
that is why
the message is a passion,
that is
and
why we
respect.
run our indelible signature program on the afternoon of the last day of the silent mentor, because our mentors deserve good closure. And this is to reinforce to people that the way you close and handle the tissues will significantly affect the appearance of the wound thereafter. And that is your indelible signature. And that is why you need to pay attention. But the principles of alignment and needle rotation and equal and opposite, this dislocation and slip, apply to every aspect of surgery, whether it's small vessels or large vessels. And I urge you to practice with your needles accordingly. Any other observations? Anything from the audience? Well, thank you very much indeed, ladies and gentlemen, for participating. If you have found this valuable, please tell your friends, and I look forward to seeing you back next week. I note in the participant group we have some new names. Thank you very much for joining. I hope this has been helpful for you, and we look forward to seeing you next week, where we are going to discuss in detail the anatomy of the needle. Until then, keep well and keep practicing. Thank you, fellow senseis, Chris Cuddy, Prof. Sile, most kind. Thank you very much. We have got a feedback form that we're going to send out to you at a later date. Our production person is not here, and I'm afraid, just as in surgery, you can't do it without a team. So please, when you receive the email, to fill in the feedback form, we'd appreciate your feedback. Thank you very much indeed.